All right, so the question of the topic for tonight, not the topic. The question is, your dad's turning 65. He's a chemical engineer, and we got to get him a gift.
Yeah, I thought it was his 64th birthday, one of the Omaha Steaks birthdays, but no, this is a big one. This is a real one I got to figure out. So any ideas are greatly appreciated at this time to help with that, because I got nothing. And my brother's useless, so he's got nothing.
Oh, man. All right, so I didn't know there were Omaha Steak birthdays.
Well, I mean, they're just like, oh, that's tomorrow. But they'll get there in time. That's what we can get to him. But no, I need a good gift. You're almost there. Sunset years. You're gonna enjoy life.
Got it.
But I really don't know.
Well, hey, let's audience. Those of you joining us, thanks for coming. I see Frank, Gina, Ken. Oh, now my screen's all like everybody's adding in. Amy. Hey, why don't you guys tell us two things, if you would. Please hit us in the chat. That should be activated for everybody. Please tell us where you are tuning in from. And if it were your chemical engineer father's 65th birthday coming up, what would you buy him? That's the question, guys. So where are you from? Tell us what you'd buy your dad if you're Andy. Hopefully he's not going to watch this webinar.
Literally no wrong answers to this question, because right now it's nothing.
Well, I have to say, I don't know. I'm usually the one that's like freaking out in advance about gift giving, because there's such a big deal. And there's really not.
I know, but
by and large, right?
Maybe I'm putting more weight on this than it really needs to have. That maybe he won't even remember it's his birthday. Who knows? That could happen. Maybe he'll forget.
Yeah. All right. So we got Denver bottle of scotch. Randall's in Idaho. As a matter of fact, my dad was a chemical engineer and probably got him a pair of socks.
Okay. Well, again.
You can't go
wrong ideas, but there are ideas that may have more merit. But he wears shoes, so that's a good starting point.
Socks, scotch,
could at least buy some time. Yeah, he's more of an IPA guy, so maybe we'll go that route if we go the alcohol. But I think that was Christmas last year. I did a beers from around the country pack. So then you get into the repeat.
There you go.
It's tough being the oldest son. This doesn't fall on the youngest. This is the firm responsibility of the heir to the family name.
Well, speaking of heirs to the family name, no, I'm just kidding. We can't go there tonight. We don't have time for that. We're going to stay on this continent. No, hey guys. So thank you all for joining us. It's a minute after 5, so we're going to get started to respect your time. If you've been here before, we welcome you back. If this is your first time, you're here for the other guy, not for me. I'm Michael Cohen. I'm the CEO here at Awaken to Sleep. I'll be the moderator, not the speaker tonight. We've got Dr. Andy Swiatowicz. I hope I said that right.
That was perfect. Better than most people.
All right. Guys, we're here to talk about digital workflows in dental sleep medicine. We want to deliver some great content, add a little flair, a little fun, and hang out with you tonight. We understand you can see us and we can't see you. Don't fall asleep doing webinar CE like nothing. Just don't go out like that. But speaking of CEs, we got a couple of requirements. As you know, you can get one CE for tonight through AGD PACE, issued by Awaken to Sleep, but you have to actually hang out with us for the webinar. So if we're asking questions, please hit us in the chat. If you have questions, please put those in the Q&A. We will stay here until we answer every one of your questions tonight. That's why we're here. Other than that, you're going to get a link for your CE at the end of tonight in the chat, as well as emailed to you 1 hour after we are finished. If you don't have an email 1 hour after we're finished here tonight, it is in your spam, I promise. But that link will take you about 17 and a half seconds to complete. So please make sure you do that. That's how you get your CE certs for tonight. All right, enough of that nonsense. Everybody's heard that a bunch. Let me tell you about this guy. Dr. Andy. He graduated University of Maryland School of Dentistry in 2010, did his GPR 2011 at Wilmington Hospital. 7 years later, got your diplomat, the AADSM. That didn't take long, man. I got to hear some of that. Currently, he owns two very distinct practices. One in general dentistry that's focused on occlusion, excellence in care, and has a specific niche of working with patients who have intellectual and developmental disabilities. Second practice is DSM only. He was the first DSM practice in Delaware called Delaware Dental Sleep Medicine. Currently collaborate with lots of healthcare professionals. We were talking about that in our practice session here. And in your spare time, you're the section chief of dental sleep medicine and specialty care dentistry at Christiana Care Health Systems.
Yep. And
you're on the board? I mean, kind of busy.
My office, if any of them are here tonight, will tell you I don't have a lot of free time.
That sounds like it, man. But you do collect art, if I remember right. I didn't have that in my notes. I see some cool stuff in the background. But yeah, I mean, hey, so tell us, Andy. I mean, I know you don't like talking about yourself because you're a humble dude. We appreciate that. And at the same time, before you get into the content, if you can just tell us a little bit of your journey getting into sleep, what has really mattered to you, kind of your why, and take us off, man.
Yeah, definitely. And actually, that's always my first few intro slides. So we'll get into that. So welcome, everybody. And thanks for spending some time tonight. For those of you on the East Coast, a little bit later in the evening. And for those of you on the West Coast, right after work. So we're going to be talking tonight about digital workflows and how I utilize them in my dental sleep practice. And we'll touch on a variety of different technologies, mainly digital impressions and 3D printing, and how that plays a role in enhancing our patient care. And let's see, oh, there's a little spinning graphic there. So first, again, I got to do boring stuff too. No disclosures to report here, not being paid by anyone or anything. Any products that I reference here, people, services, they're not endorsements. They're just things that I've encountered along my dental career that I thought are noteworthy and worth talking about. So you mentioned, Michael, about my why and how this kind of all started for me. And sleep apnea, it's really been a part of my entire life. I mean, as a child, I was an apneic patient, and here I am, and I'm kind of a classic apneic kid here, sleeping on my chest instead of my back, mouth open, dark circles under the eye, so tired that I don't even notice a cat is on me. That's how bad my sleep disturbed breathing was. And it's something that I've always dealt with. I mean, as a rower in college, nobody wanted to room with me, but because I was the loud kid in the room at night when I would snore. Now, luckily I was a pretty good rower, so it made up for it when we were on the water, but still, it just gave me more space in the rooms at night. But finally, benefits. Yeah, exactly. This apneic patients always know what they're doing. They just like space. That's what it really is. Yeah. But what happened in then 2016, I decided, you want to know what? I'm starting to talk the talk. I need to walk the walk. And I decided to get myself treated for my sleep apnea. So went to an ENT, got evaluated, and signed up for surgery because I had large tonsils, adenoids, deviated septum, hypertrophic turbinate. So we said, you want to know what? Let's start the surgical route. Because at this point in my life, and this was back, like I said, in 2016, I would wake up every night, normally 6-7 times a night, almost always to go to the bathroom, which if you're, depending on where you are in your sleep journey, you know, that can be one of those telltale signs of sleep apnea. So I decided it's time, we're doing it, scheduled the surgery, and we're in spring 2016 at this point, and I'm driving into work, beautiful day, sun is shining, not a cloud in the sky, things look great. And then suddenly as I'm driving by the high school on the way, next thing I know, I am the final of 5 cars in a accident. So all these cars were already collided with each other in front of me. And then I was the last person to hit. Airbag goes off, car is totaled. Nobody was hurt. Guy, who unfortunately caused the whole thing, fled. But who knows? Hindsight's 2020, but AAA notes that a third of all motor vehicle accidents are a result of drowsy driving. I was an untreated apneic patient at this time. The odds are the reason I didn't see 4 cars that had collided with each other in front of me was because I just wasn't aware because of my disturbed sleep all night. So that really got me like, okay, I made the right choice. Surgery's coming up, which, side note, if you ever want the easiest way to buy a new car, get your tonsils out, and then you just email all the dealers and say, had surgery, can't talk, I have to do this by email. They call you, you say, you don't listen, I'm not dealing with you, and you just buy a car via email and get all the same service. So there's the hidden pearl for tonight. That's all there is to it. But in all seriousness, I went and got treated, septoplasty, turbinectomy, adenoids, tonsils removed, life-changing. Really improved my sleep. It was fantastic. I don't wake up anymore. Allergy season comes along and some rough nights. I still have a little bit of congestion that I'll wear my oral appliance to give me that last little kick over the finish line to have a good night's sleep. And it really is so impactful. And I love talking to patients about that because I'm an apneic just like them. And it helps us relate to them and really get some treatment acceptance with it. But I'm a believer in it because I am my own patient. Now, of course, as a doctor, I'm also my own worst patient, but that's neither here nor there. So like I said, was introduced as, I've got my general practice at my lovely office there, one of the most beautiful gardens, if I do say so myself. And we are fully functional general practice. And although I've been doing dental sleep appliances since dental school, where one of my mentors, Karen Ferrone, said one day, do you want to make a tap appliance? And I said, sure, that sounds fun. Why not? My patient didn't show up. So we took some alginates, blocked out the undercuts with plaster, sent it to the lab, bada bing, bada boom. That's all there was to it, which I now know there's a lot more to it. But I had that experience early on, was building it into my practice. And then we started our own practice dedicated solely to sleep-related breathing disorders in adults and children. And it's grown, and it's been a professionally rewarding thing for me to do, to help patients differently. And really, some of my favorite days in my office are when we're doing just sleep, and that's at least once a week here. I still have a special place in my heart for general dentistry. I love occlusion, I love splints, I love doing these full mouth cases, and even just the run-of-the-mill class 2. So I'm a firm believer in, you don't have to give up the general to do the sleep, which I know some people are. Some people go full sleep. Whatever you think is best for you. But that's a little bit about my my journey and my story with how this all began.
That's awesome, man. Hey, so this is kind of, I don't normally start with the comical questions. Those are usually like tailored in the end. But I got to ask you, because people are asking, what's the dinosaur's name in your garden?
Oh, see, to be fair, there are 2 dinosaurs. We'll meet the other one later, but that is Flossie, the Bicuspisaurus Rex. Actually, when I bought that building, you know how in some cities they have those little fiberglass whatevers, Saratoga Springs is horses, Baltimore is crabs. Delaware, for some reason, is dinosaurs. And that building, when I bought it, had one out there, but it was all money themed on it. And it was the the dollar dino. And the last thing you want somebody seeing when they come into a dental office is a reminder they're going to pay money. So luckily I have a patient who's a muralist, and he gave it a nice, more appropriate theme. So Flossie is a big hit. The kids love it. So come out and see us.
Cool.
All right. So like I said, we're talking about digital workflows tonight, and we're all on a different path, I would imagine, in the group here, of our sleep journey. Some of you may just be saying, hey, is this right for me? Some of you may be saying, I've been doing this for a minute and I just want to see some of this cool new stuff that's coming out there. So like I said, we're going to, for the sake of completeness, kind of give some crash courses on obstructive sleep apnea. We'll keep it 4 minutes on less or less. That's all you need to know about it. And then we'll get into the meat of the presentation, talking about digital impressions and 3D printing, going over what my digital workflow is in the office and how we utilize these technologies. And then taking a look at the end about how we enhance our patient outcomes by using 3D printing digital impressions. And we'll go over a couple of case studies that I have to show you. So starting off, crash course in sleep apnea. We'll put the timer on the clock. So what is sleep? We know it's not a turning off. It's a highly organized neuronal process that's easily reversible period of quiescence, where you have a decreased response to stimulus, but a lot of stuff is happening there. You're having a lot of neurological things go on, physiologic things, and that's critical for our health and well-being. Our sleep progresses through a variety of cycles of non-rapid eye movement and rapid eye movement sleep that have very distinct things happen during each phase. And we want to get about 4 to 6 of those cycles a night, and they last about 90 minutes each. But the problem becomes when we wake up, we don't start where we left off. We have to kind of recalibrate and get that ball rolling again. And because of that, and not getting the full benefits on the physiologic and neurologic level, that's where the negative effects of disturbed sleep start to happen. Bunch of different sleep disorders out there, divided in a variety of categories. You have your insomnias, your sleep-related breathing disorders, which is something that we as dentists can help participate in the care and management of for our patients. You have your hypersomnias, or too much sleep, the cute little narcoleptic goats that fall down. If you haven't seen those, go on YouTube and just waste the night after this presentation watching that. You have your circadian rhythm disorders like jet lag or shift work syndrome, your parasomnias, or abnormal, undesirable physical things that happen during sleep. And these can be things like sleepwalking, sleep talking, sleep eating, bedwetting, sleep texting, and the ever horrifying exploding head syndrome, which is a real thing where only you hear an explosion go off in your head. And every night I'm thankful that I am not diagnosed with that. You have your sleep-related movement disorders, which are things like restless leg syndrome, periodic limb movements, and another thing that we as dentists encounter on a daily basis, nocturnal bruxism. And then you have some catch-all categories of other. When we look at apnea, which again, Greek for without wind, what happens with normal breathing is you breathe in and out, ideally through your nose. When the diaphragm contracts, fills the lungs, oxygen diffuses throughout the body. Great, that's the way it's supposed to work. However, with obstructive sleep apnea, you get a blockage, usually that tongue falling over the back of the throat there. Your brain tells you to breathe, your diaphragm contracts, so you're trying to get that air in, you can't, and your body awakens to allow you to start breathing again. We as dentists can really help our patients manage that obstructive sleep apnea. And then you have central sleep apnea. When your brain doesn't tell you to breathe. That's where we want to be able to identify sleep disorders in patients and help them get treated properly and get the appropriate medical care that they'll need for it. Now, I said earlier, the disrupted sleep impacts your health. And really the biggest thing we're going to see is the effects on the cardiovascular system are going to be a huge stress on the body when you don't breathe. Breathing against a closed airway will cause a variety of hormone signal cascades that happen. You'll have oxidative damage. The lack of oxygen is obviously bad for the body. And you have this constant sympathetic activation that's really putting you in fight or flight mode all night. But like I said, cardiovascular events are key. Thing you can take away tomorrow on your first hygiene check, if you've got a patient who's updating their medical history and telling you their new blood pressure medications again, or the changes in doses. Drug-resistant hypertension is one of those key signs of untreated obstructive sleep apnea. Know it, identify it, talk to your patients about getting tested by their doctor. But things like atrial fibrillation and stroke are also some of the negative impacts, and you have worse outcomes if you're untreated. Many patients get diagnosed with insomnia after their sleep apnea is finally treated and managed successfully. We know that you have a buildup of beta amyloid plaques in your brain. And normally as you go through those sleep cycles, you'll have the lymphatic system wash out all those waste products. But if you don't have uninterrupted sleep, you'll have the buildup of the products, and it can be tied to dementia. Nocturia, increased urination, was one of the huge signs for myself. It's not because you drank a bottle of water before bed. It's because of sleep apnea. And we don't need to worry about the whole cascades of the why, but this will be your biggest resistance from your older male patients, because they'll just say it's guy stuff. Don't worry about it. It's fine. I'm seeing the urologist. But it really can be sleep apnea as a key part to it. And when it comes to kids, ADD and ADHD, the standard of care, if a child starts to exhibit those symptoms, is not to put them on medications that are stimulants to help with their underlying sleep problem causing it. It's to evaluate for sleep disturbed breathing. And if present, really first line of defense, adenoids and tonsils, but also look into orthodontics to expand the jaws and grow that airway to help prevent problems in the future. Now, we know everybody dies. If you didn't, I'm sorry to be the one to break that to you, but apneic patients die sooner. There's a 4 to 5-fold increase in mortality with untreated sleep apnea, reducing life expectancy by about 5 to 7 years. And most of this data comes from the Wisconsin sleep cohort. It's data that's been collected on people since the late 80s, and it's continuing to be updated on a variety of health things, but this is where we get a lot of good sleep information. And what we find out is treating sleep apnea improves mortality rates. You're going to live longer. So when you have a patient who says, oh, I tried CPAP, I got really bad sleep apnea, but I just couldn't wear it, so I stopped. Well, what do you want to do in those next 7 years? Do you want to see your grandkids graduate, dance with their grandkids at their wedding, become a great grandparent? A lot can happen in that time. Or say, screw the grandkids, I'm traveling the world and enjoying life. It's a big amount of time. And if you can improve that mortality by treating their sleep apnea and finding a way that works with the patient, that's helpful. Now, on the medical side, go-to is going to be PAP therapy. And we know patients know about it, and most patients hate it. You have to be a very skilled clinician to guide a patient to acceptance and success with PAP. You can go the way I went and cut things out of the way, move the jaws, a lot of different options out there that really do have some high success rate, but a shelf life. You have hypoglossal nerve stimulation, or Inspire, another great therapy available for patients. Lifestyle changes, behavioral changes, improvement in sleep hygiene, cognitive behavioral therapy. And of course, medications are out there too to help improve sleep. And that's a big area where, as we understand the phenotypes of sleep apnea, where we can start targeting medications and then combining them with medications to counteract the side effects of those medications. But it is promising to help patients manage sleep apnea, not just manage the sleepiness that comes afterwards. In the dental world, our go-to is going to be oral appliance therapy. And it's what most of us do and most of us know about. And it works. There are over 125 different appliances out there. They do the same thing. They hold the jaw forward, pulling the tongue off the back of the throat, preventing relapse, tightening the tissues, allowing you to breathe more naturally. But that's not all we have. We can also do frenectomies to help with tongue movement, expansion of the jaws, tooth-born in children, or micro-implant assisted rapid palatal expansion in adults. I'm fortunate enough to have in my neck of the woods Mariana Evans, who's a brilliant clinician. I fanboy over her all the time because she's great at what she does. She has the data to prove that the jaws can be expanded in adults, and it can work to improve nasal airway, jaw size, and help patients manage those conditions. Myofunctional therapy, a lot of hygienists out there are getting into that, and doctors too. And again, that will help. Snoring can be alleviated by lasers, and lasers are finding more and more of a role in the dental sleep world. And even something called Excite OSA, basically a vibrator for the tongue, stimulating those muscle fibers to become a little more responsive there to help with that genioglossus, getting it off the back of your throat. being more responsive to some of the natural things the body does. So that's sleep apnea 101. Now we're moving on to some of the fun stuff where we're going to take a look at digital impressions and 3D printing. Now, most of us, I'm going to assume, are aware of digital impressions, and probably a lot of us are using them already. And they've been around for a while. And patients, when they hear the word impression, we know this is what they think. The goop, the mess, the gag, the taste, hating it. I still have patients who, when they're getting their first digital impression with me, are blown away by the fact that this is even a technology, and why haven't they had this before? We've been using it in my office since 2012. I remember, though, in dental school, when I went home to my dentist, she was got one of the original iTeros, and she was showing me all that cool stuff and the models, and it's changed dramatically since then. For those of you who don't use digital impressions or aren't quite sure how they work, really it's a video or a photographic capture of shining the light onto the tissues, imaging sensors taking in that reflected data and generating a 3D model off of that live in front of your screen. I mean, I remember my original iTero was you used the foot pedal and you took pictures that had to overlap, and if you did something wrong or you moved, it made this horrible beeping sound that would keep me up at night. Most of them are going to be live video captures that just as you're moving around, and I'll show you a live demonstration of this a little later in the presentation, it's going to construct that model in real time. So as I was preparing this lecture, and out of curiosity, I just went back to the JADA archives, and it's like, how did we talk about digital impressions in the past? Oops, sorry there. Oh. So a lot of different systems out there. Sorry, skip the slide. But I've used a lot over the years. I was an iTero user, currently using the Medit. The residency program I teach at uses, I believe, Trios, or that is the most recent one they have there. So you can certainly have your pick of the technology and just find what works best for you or what you think you'll utilize the best there. So looking back at some of those headlines in the JADA research there, you can see that it was almost like a contentious thing that these digital impressions were going to put on their gloves and go against the PVS and see who came out on top. But we now know through studies done by the ADA that most offices are using digital impressions, 53% in fact. So you can say digital impressions won, but main reason people do it is to improve their clinical efficiency and improve patient outcomes. And the biggest reason not to is cost, and there is a cost associated with it. I think it's worth it. I wouldn't think twice about buying a scanner, knowing what I know now. So banks give out free money still, it'll be fine. But it really is a cool piece of technology that will pay for itself with time. And again, back in 2014, when the ADA asked dentists what the main advantage was, it was better outcomes of digital impressions versus the conventional methods. And when they actually broke down the timing of how long does it take to do a PVS crown impression, following manufacturer's instructions, doing all the steps appropriately, it ended up being 18 to 27 minutes to do, with 7 to 13 minutes of that being intraoral working time. And when you compare that to digital impressions, it was 4 to 6 minutes to do a single crown scan, and only 1 to 3 minutes of that was in the mouth. So you're saving 23 minutes. And with a well-trained assistant and good systems in place, you can speed up that process even further for your office. Now, looking at dental sleep medicine, we've got some more specific things that can be really helpful to enhance our care for our patients. And most importantly, you get a super accurate impression of the hard and soft tissues of the mouth. Sometimes too accurate, especially when you're talking about making a milled appliance. They're typically not going to make it on the model. So they have a digital file and they'll use that to create everything. So you have to really be able to communicate to the lab, yeah, I know this is a great impression. It's got all the detail. I don't want you engaging this area because maybe there's some aesthetic work on the front teeth, or these undercuts and these embrasures. I don't want too much retention there because I'm worried the patient's going to have a hard time getting it out. And that's something you fine tune with time. And when you continue to have your relationships with the labs, they kind of know what you want. Importantly, and this is talking from, oh, sorry.
No, Andy, I don't want to stop your flow here, but I do have a question because I know this is something that comes up frequently in our coaching. When you have an intraoral scanner, you're doing dual arches, upper and lower, wrapping the furthest molars. How do you do that with a patient that has minimal opening, minimal ability to, they don't have TMD issues, there's no pain, but how do you deal with that?
Well, the good news is it's a hell of a lot easier than it used to be because these scanner heads have gotten a lot smaller. So that's a great, if you're just starting getting into the technology, you're doing it at a great time because I mean, the camera heads used to be pretty substantial, but I can't remember the last time I have not been able to get everything I needed to on the impression. And it's just finding what works to maneuver in your hands, having the patient's help, knowing when to have them open or close to help relieve tissues and get to those areas.
Got it.
And sometimes saying, that partially erupted third molar really isn't going to be too important for my sleep appliance. So we're going to say A for effort, B+ for execution, and we're still going to get an appliance that's retained and going to prevent any real changes of side effects. But it really is a good physical thing to do with your hands to see what works best. And it comes from experience. The more you do it, the quicker you go. And it's actually, it's kind of good you talked about this because the scan that I'm going to show in the next slides, I scanned one of my assistants in the office, Dory, and I picked the wrong assistant because she has very great opening. That's not the problem. And she sat there and let me mess around for a while, but very nondescript anatomy on parts of her teeth, which are a little harder to piece together for the scanner. So, but I was committed at this point. I wasn't finding a new assistant. So I'm like, we're just going to use her and we'll say, see, even somebody doing it for a decade still runs into these things.
Great answer, man. Thank you.
No problem. So again, another benefit that really pertained to my case was it gives you a chance to evaluate the protrusive bite in real time without all that other stuff around there. Patients deviate when they open or when they slide forward or deflect slightly, and you need to communicate that to the lab or you're going to exacerbate some TMD symptoms that we'll talk about a little later. For example, when I made my first appliance in 2016 on myself, I didn't tell the lab that, oh, I deviate about 2 millimeters to the left at that position. So when they got the models, and I had to print out the models to give them for this course, they just did midline to midline based on the information I gave them. And I had some pretty bad jaw pain early on. That luckily I knew how to relieve and how to adjust. But if that's something you can avoid ahead of time and make sure the information you captured correlates to what you see clinically, you're going to have so much more success and ease with the follow-ups of the patients. As with all digital impressions, it's a great education tool. You really show them, hey, this is what I see. And in the world of dental sleep, it's primarily not saying, oh, look at that crack on the mesial marginal ridge of 3, or do you notice those abfractions you may grind? I'm talking about, look at how narrow your jaw is. We're going to make an oral appliance for you. It's going to give us a good result. We may want to have conversations in the future about going into some type of orthodontics to grow your jaw because the roof of the mouth is the floor of the nose. And so if you have a really narrow palate, that's going right up into the nasal cavity, making it hard to breathe through the nose, making you breathe through the mouth, making you open and send that tissue back onto the airway, putting pressure on it and closing it. So it's a way to start educating the patient on things that may be needed to help them be successful. Delaware, we have to keep models for 7 years. I make a lot of models. When they're in the cloud, I don't care how many I have. I take models for fun. sometimes. Let's do this on a patient. So we have that, but that's also important when it comes to needing to recreate things for the patients. And as I'll show you at the end of the presentation in a case study, we do have the ability to compare the position of the teeth with time, and we know we can have modifications to tooth position, bite, that we want to try to catch early so we can reverse. And that's where being able to compare teeth year to year can be really helpful. So like I said, here's my assistant scanning for the full mouth. Maybe there we go. So again, this is my lovely assistant, Dory. She did a great job sitting there and letting me do this. But this isn't a double time scan here, but a full arch on a more, I would say, difficult case, or a patient who presented with a few more problems in the scanning process because of the anatomy of her teeth. Took me 3 minutes and 57 seconds to collect all the data that I needed. So upper arch is done. We're going to her bottom teeth here. And one of the things that will, it's cool to point out here is the software. At one point, I moved the scanner off of the scan area and it had to start over again. And there it was. It stitches that together and is able to piece together that information with the model you're creating. And in the end, some of that junk data there, that fuzziness gets cleaned up. I'll show you the final models at the very end there. So we capture all that information. And again, this is something my assistant's doing for me before I even get in the room. So a lot of times I get to do what you mentioned earlier, the most distal part of the tooth, the hard part. They get me everything else, and I get to be the bad guy who goes back there. But it's good teamwork and a good flow for the office too. So that was getting the full arches. And then another important thing to do is to take our bite registration. I take both a MI bite, so I know what that initial occlusion was on the patient. Again, with the Medit scanner I'm using in the software, if it's having a hard time in a patient with that nondescript anatomy picking things up, you have the ability to stitch it together by telling the lab, hey, or telling the software, here's the molar here and here, and then it pieces it together. And then we take the protrusive bite too. And I use the airway metrics jigs in my office to determine that initial therapeutic position that has both the vertical and horizontal component. I'm also a big fan of pink futar because that thing is tough. But when it comes to scanning a protrusive bite where you have that vertical opening, so now you've got airspace that isn't really going to be something that can be picked up. If you go all the way distal to where that futar is, it gives you a nice positive area, and you could see it picked up there to help capture that occlusion and trace so you get the top and bottom so it can join together. So in the end, again, 3 minutes, 57 seconds to do upper arch, lower arch, MI bite, and protrusive bite. And then the software does its magic, makes these models for us there, and you can see you get a really clean and detailed impression. There's her and her MI bite, looking at the arches on their own. Hopefully everything's coming in clear for you guys there. And then taking a look at the occlusion together too. So this is kind of my checks and balance before it sends to the lab. I want to make sure I've got all the information to make a retentive appliance that's going to be functional for the patient. And this really is where that comes into play. I think, yeah, we showed the protrusive bite like I talked about earlier. We want to make sure we've got that appropriate vertical space for the appliance to fit, but that we're also taking into account how the patient moves their jaw. So that's a little bit about our digital impressions. Now we move to my new favorite toy, my 3D printer. And I love this thing more than the children I don't have right now. So it's just such a cool toy that's really been across the board beneficial to our practice. So a lot of us are familiar with digital technologies on dentistry, more so on the CAD/CAM subtractive milling, where you cut things out of things. 3D printing is done differently. It's additive. You're building things up in layers to make models, splints, a variety of things out there. Most use a vat polymerization where you have a tub of liquid where that platform goes down into, and then photopolymers will selectively cure based on a light source to make those models build up in those layers. It's a cool process to watch. I recorded a time-lapse video of using just splints, which don't really come up and down a lot, so it really didn't translate well watching it. But anyway, like I said, lots of different types of printers out there. Currently, we've used Formlabs in the past. I'm currently using Sprint Ray printers there, but there are lots of different ways to generate that model and begin that photopolymerization. You have stereolithography, which is where a laser is going to continuously move across that build platform to cause that layer to form. You have digital light process where the light kind of shines and does the whole layer at a time. And I'll have a quick video after this to go over 3 of the versions. Selective laser sintering, which opens up to some new forms of materials to print. Liquid crystal displays using LEDs and screens that kind of limit where the light is going to for polymerization. And material jetting, which is like an inkjet printer and building things up in those layers. And what's cool with that type of stuff is you can do different materials, different colors that I'm sure we'll be able to utilize more and more in dentistry. So hopefully the audio's coming through here. I, of course, can hear it.
We're not hearing it, Andy.
Oh, we're not hearing anything?
No.
Oh.
If you want to,
it's
yeah,
the words are on the bottom too, so
okay.
I won't add too much, but it's just showing how those 3 main layers of things actually.
Are we hearing it now?
But regardless, this is showing you have that polymerization where that build platform goes down, builds, and comes up. When you look at it there, you have the. Here we go. This will break down those 3 in a little more detail. So digital light processing, again, is going to be what I'm currently using with the Sprint Ray printer. And it shines that light source of the entire layer it wants to print onto the tank. And that's going to build up that platform in a layer. So it's a little more expedited of a process because you can see we're doing a layer at a time. And this is a video from Sprint Ray, so they're a little biased in how they talk about it because this is theirs, but I do like that they go over all of them. LCD, you're going to have a screen that goes that the LCD is projected through.
The light used to cure resin is damaging the organic compounds in LCD screens. Therefore, most LCD printers treat their light sources.
The main thing they're telling us here is that it's going to cost a little more to do this because that screen doesn't last the entire time. And then you go over your lasers, your SLA, where you can see it's kind of printing off everything, not in one layer, but in increments of each layer. So it's going to take a little more time to do that, but it's also going to be pretty accurate too. So you have to kind of figure out what's going to work best for your practice of these methods. And that's something to really go to an office that's doing it and figure out what's working out best for them and see if you can do some stuff with them and go from there and make that good decision. So sorry, it was a great video, actually. I'm sorry the audio didn't go through, but moving on. So 3D printing really has a lot of uses in dentistry, but when I'm looking at any technology, I'm looking at ways to have a good ROI for both of my practices. I don't want something where I can only use it for a tiny little thing. And really 3D printing can be used for a ton of things within your dental practice, general sleep, whatever you have. The gateway drug is always going to be models, printing out study models to educate patients with, to make things on, to do digital wax up or changes and make that model and develop your stent or guide to go through that aesthetic case. Or maybe you, like I said, want to make retainers or aligners for orthodontics on those models, print them out yourself and do the suck downs. I designed my own bite splints on a software called D3 Splint, and then we print that out and work out all the occlusion on a digital articulator ahead of time. If you're on the surgical end, if you want a surgical guide for your implants, you can plan that case ahead of time. Or print your own dentures if you want. That's a little beyond what I would do, but that technology is out there. And most recently too, for the general offices, printing temporary crowns and bridges ahead of time for patients. And recently materials have been cleared by the FDA to allow for permanent final indirect resin restorations. And the materials are only going to improve with time, and the speed and the techniques. And usually with that, the cost will go down too. So we're at just the tip of the iceberg of how we can utilize 3D printing across dentistry. And what you can become is your own lab, which is depending on how much you like lab work, a good or a bad thing, but you can utilize it to its fullest potential, collaborate with your lab to speed up the process of making things maybe you don't want to design, but they can, and they'll send you the STL file. It really is a cool time to be with technology and dentistry because you really do have a lot at your hands to take advantage of. Now, when it comes to digital design and 3D printing in dental sleep medicine, we use it for a variety of things, whether we want to make models to make retainers for patients to help minimize any shifting of the teeth, making our morning aligners, splint therapy. Huge fan of it. And a lot of patients who come to me with initial TMD symptoms, they'll get a morning aligner and they'll get a bite splint to help kind of return them to normal. Some of my mentors and great all-around guys out of Richmond, Michael Pagano and Alex Vaughn, they got me going on this 3D printing and really wanting to do more with it, but they're leaps and bounds ahead of me with what they can do. But even making temporary appliances to give patient a trial run, because seeing all that plastic on a model, saying, I don't know if this is for me, if you can give them something to feel and experience, that can be out there. Now, it's important to note that a oral appliance is a Class 2 medical device that's regulated by the FDA. So you can't print final appliances yet. I'm hoping it'll change one day, but you can still make something for a patient, even with some little wings on the side, to see if they can tolerate it. And you can modify existing appliances, maybe make some custom things to bond to it to increase the vertical if you need to go that route for your patient. So I'll just show you real quick, start to finish, making the morning aligners for a patient. We don't really use thermacryl anymore for anyone. We make these, and this typically goes on with the patient still in the chair. My wonderful assistant, Bree, she will be getting the patient set up for their next appointment, answering any last minute questions. And I'm usually, in a perfect world, designing this at the same time. So Bree can go down and print it when she's ready to. And I'm talking here as I'm an expert on the actual printing end. It's great to have team members who want to learn and you can encourage to learn and do their own things, but Bree runs the printer and the processing and getting everything ready. I can figure it out. Luckily, technology is, you can do very little things that are irreversible. So I don't mess it up too much for her, but I let her control that area. And it's really been a great partnership in being able to make these appliances and do the printing for the patients in our dental practice and our sleep practice. So you can see this is that D3 tool software where we're finalizing this morning occlusal guide. And if you're not making morning occlusal guides to help patients get back to normal, you have to be. And I'll show you why in our case studies here at the end. But this is all there is to it. 5 minutes and 40 seconds from opening the software to uploading the STL file, even having my crazy OCD and putting the patient's name engraved into the side of it, which Swiatowicz, that's a little small, but it's easy when there's a 4-letter name, you're able to get that a little better in there. So you upload it into their chart, and then Bree's ready to go to print that out. So that's a little more detail on 3D printing. Now I just want to touch base on how we use this, what our workflow looks like through patient start to finish here. So at our initial appointment, Bree's going to bring the patient back, update their medical history, go over their sleep history, get a Panorex, and do that scan. Get those digital records starting for me. She'll do the arches, the bite, and then as the doctor, I'm going to take the scan of that therapeutic position. Again, consult your state laws on what is appropriate for assistants to do and doctors to do. But it's also good to be the doctor to have hands in the mouth and show some ownership. I usually say, Bree did all the hard part, and now I just get to come in and be the hero and cure you. But it's a good, like I said, collaboration there. So that's our initial appointment. We'll design the appliance. We'll send our morning aligner. We'll send the models off to the lab, and it'll begin that process of fabrication. We get to delivery, and if we've got a really good model that we told the lab what needed to be adjusted on it, it drops in. If it doesn't drop in, it's really a good chance for me to go back and say, all right, what did I miss? What did I not communicate with the lab? And if you've ever had a digital impression rep come into your office, one of the things they'll say is, it makes you a better dentist. And you kind of brush it aside, like, whatever, dude, just, I'm committed here. You don't have to give me the fluff stuff. But it really does. When you can critically evaluate that and say, what did I do? What can I do differently? What can I do better? That's where that comes into play. We have our follow-up appointments and titration studies. Patient is cured. Yay, success. But at those annual recalls, that's when we're going to bust out the technology again. Maybe is almost definitely, the patient has lost their morning occlusal guide. Okay, we can print out another one. We have that STL file ready to go and the ability to print it. We could even at that appointment for them. And we're going to rescan them to see if there's been any shifting in the occlusion or the position of the teeth. Technology in a dental practice and a dental sleep practice isn't all fun toys like scanners and printers, though. We also use a software called Slack to help us move through the patient care process, where we tie in Brianna, my sleep coordinator, who does all the admin side, Brianna, who's the assistant. Very confusing at times, but a good rule of thumb at my practice is, if you need to mention somebody by name, just say Brianna. You could call me Brianna if you want, and it would probably be all right. But we use this technology to go through step by step to communicate to each other that, hey, okay, we did the exam, Dr. Swiatowicz, can you design that appliance? Okay, I designed the appliance. Bree gets a notification, appliance is ready to go. Let's print it out. Microsoft Teams is another good software that you can use, but if you haven't explored different ways to improve the back-end efficiencies, not just the clinical side of things, I would encourage you to do so, because it really can be a way to utilize technology to improve the overall experience for yourself and your patient. So when we're going through our practice and we're looking at the digital workflow, we scan, we plan, we print, and we have a happy patient. It's amazing when I was going in Canva to make some of these slides, and you just type in dental patient thumbs up, dental patient high five. There are a lot of stock photos you can use of that. You almost wonder what these people thought they were posing for, but these guys were for a lecture on dental technologies. So that's kind of our workflow on how to use these digital technologies. But now I want to show you how we can use this technology to improve patient care, improve patient outcome, because that's what we're trying to do as clinicians. We're trying to be better for our patients and have a better experience and better outcomes for them. So what do we see when we start to utilize technology more? We have a quicker turnaround from the lab. There's no shipping, there's no pickups. Well, I mean, there is shipping back, but you're saving time on the front end. You have a precision fit appliance that's really going to be custom made for them and really going to be accurate. And that's going to help with comfort and accuracy. If a patient loses something, they break something, you need to realign with time, you can do that in a quicker way too. You can print out that bite splint or that morning occlusal guide when the patient tells you they lost it. You can have the lab say, hey, here's the models again, in case you don't have them, I need you to make another appliance to the same specs as before. You could print out a model and reline it with material to help tighten it up on the teeth without having to do it in the patient's mouth. And importantly, you're going to be able to help reverse and lessen the side effects of oral appliance therapy. And there are side effects. These are well accepted and well documented and studied in the literature. TMJ side effects, soft tissue, bite changes, damage to the teeth, appliance issues. Again, great article that's referenced on the bottom. It may be a little blurry there, but that was in a Journal of the Dental Sleep Medicine back in 2017. Very extensive article. I would encourage you to read if you haven't done so already. But you can have issues with appliance. Again, things break, nothing lasts forever. You can just make a new one, but I would caution you again from experience. If a patient says, I broke something, I lost something, and they're not a patient in your general practice, confirm that they haven't had any dental work done. Because when a patient tells you, oh, by the way, I have 3 new crowns in there, you're not going to want to just remake, you're going to want to rescan. But again, what's cool is if they just had a couple crowns that were done, you can just duplicate that model, cut out that area and save time and just get that new data put together. There will be TMJ side effects at times. And the important thing to remember is oral appliances do not cause TMD, but they can exacerbate underlying symptoms. And you just have to be able to talk to the patients ahead of time. This is where that morning occlusal guide is so important in helping to prevent this and return the patient to that habitual maximum intercuspation that they're used to. Whether or not that's the best bite for them to be or not, that's up for debate, but that's what they know, that's what they want. When you do have muscle flare up, it can be a variety of the muscles of mastication and in the neck, but main target's going to be that inferior belly of the lateral pterygoid. When we pull the jaw forward, we shorten that lateral pterygoid and introduce some trigger points. That morning occlusal guide is going to help stretch that muscle out and help get it return to normal there. Now, again, bite changes can happen. They're not always a bad thing. It may be a better position for your jaw, and your jaw may want to stay that way. This is something we talk about with patients ahead of time, that even though it may be an improvement, we want to get you back. So we tell them, you need to tell us immediately. If you feel like the the floss slides instead of snaps, or you can't bite down the same way on your teeth, let us know right away. We'll bring you in. And we can evaluate our appliance. We can take a look at our models and our digital stuff ahead of time to see if there's anything that we think could be the culprit. Now, teeth can shift. You can have changes in overbite overjet, changes in the position of the teeth, the inclination of them, the AP occlusion, the number of contacts you have. These will happen with time. Our goal is to educate and minimize and treat when it's negatively impacting the patient. I will tongue-in-cheek say to a patient, an open bite is better than an open casket. But in all seriousness, if it's important that they don't have any shifting of their teeth, oral appliances may not be the best for them long-term, but that's their decision to make. We want them to be aware of it ahead of time. So I talked about comparing position of teeth by comparing scans that are taken over different times. This patient here was convinced, again, not exactly the straightest teeth in the world, but she was convinced 23, it was moving. It was more pushed out than before. So instead of just saying, no, it looks fine, I don't see a difference, your appliance fits, we take a scan and then we actually compare here. And this is showing the patient that, okay, well, technically, yes, we're noting 0.01 or 0.1 millimeters of shifting of your teeth. Most people can't detect that. But, and interestingly enough, in this case, 23 was her bigger concern. More of the shifting was on the right side, and she didn't even notice that. But it's a good tool to use with your patients to say, I hear you, but look here. We're not really seeing that. It is minimal. But if you see something that is happening a lot, you can make some adjustments to the appliance, make them an Essex retainer to kind of help bring things back together. There are things we can do by having that digital information ahead of time where we can speed up that return to normal for the patient. And then last thing I'll touch on here, just a little more detailed case study, interestingly enough with the teacher. So I call this how I spent my summer vacation. But lovely woman, came in May 2021. She complained of snoring, heart palpitations, diagnosed with mild apnea. And I'll show you her sleep test results in the end. Deviated septum, hypertrophic turbinates, no TMJ issues, good range of motion. Slam dunk case, mild patient. This sounds great. So on July 1st of 2021, we delivered a Evo appliance and her morning occlusal guide, and comes in for her follow-ups in September. We had to reschedule a couple times because of the start of the school year and vacations. Symptoms were resolved. Things feel good. Doesn't want to do a sleep test at this time. When things calm down with the school year, she'll come back. Well, she didn't until what was supposed to be her 6-month follow-up in April 2022. And at that appointment, she tells us that, well, yeah, I lost my morning occlusal guide, and I was noticing a change in my bite, but I knew I would be coming back into you, so I didn't worry about giving you a call. So September 2021, April 2022. She goes from this, again, not the best occlusion and tooth position in the world, to this. Now, this is not her protrusive bite. This is her, I want you to curl your tongue back to your uvula and try to close down all the way. So trying to guide her into that CR position. And this is what happened. And the only reason she even came back was because she thought she chipped number 24 and her dentist wanted to do a bonding, but wanted me to take a look at some things first. No pain, no loss of function, still being managed with her sleep apnea. She didn't have a care in the world. Now I look at this, and as a Pankey trained doctor who loves perfect occlusion, this is my own personal nightmare. So we talked to her, and luckily she knew the spiel ahead of time that your bite may change. We want to know about it ahead of time. Use your morning occlusal guide. I lost it. I know I should have told you that sooner. Favorite thing to hear from a patient. But so what we did, discontinued the appliance temporarily, gave her, if you go on YouTube and look for the AADSM stretches for lateral pterygoids, great video series that we just send out to the patients and have them do that. Gave them some bite tabs and morning occlusal guide to exercises to go through. Now, again, luckily we were dealing with just a bite change, not really a tooth position change. Everything was pretty stable, maybe a little proclination of 24 there, but really not much when we compared them. So we have this bite. May of this year, we're following up, seeing how things have adjusted with her changes. We've gotten back to a good level with some of those exercises, but we're still not closed all the way. So we deliver a reverse EMA appliance to her in July. So we're pulling her jaw back. And again, we talked with her doctor, talked with her, like, your sleep apnea will not be treated in the same way during this time. We're working to recapture your bite. So we gave her a new, if you use ProSomnus, you're familiar with their MOG and MIP versions of things. So we gave her an MIP that we made, which would be, you can bite down into this all the way, you're back to your home base off of those initial models. And an MOG allows her to kind of move on them and gradually get her way back. So she's wearing it, she's shortening the bands to bring her jaw back. And we get to 8:15 of this year, and she is holding shim stock back everywhere that she should have. Her overbite and overjet hasn't been fully recaptured, but we've got overbite and overjet now. And she's overall happy with the position. My teeth were never that straight. She says, this is an okay place for me, but I would like this bonding done. So we bonded up 24 to add a little height to that there, and tell her, go back to your oral appliances, go back to that 0-0 setting. Do not lose these morning occlusal guards, and we'll give you a sleep test, advance if needed. And it was kind of cool. We just got the sleep test results in today, but when I look back at this case of how I spent my summer vacation, I really do consider it not Saved by the Bell, but Saved by the STL. You see what I did there? And again, nobody can hear the audio right now, but it's the Saved by the Bell theme song. My assistant Bree she's like, wait, you didn't put the music in? So I had to download it, but it's there and it's awesome. And this is the part where, even though we're Zoom, I'm assuming everybody is laughing at how hilarious my joke is, and you're loving it. But in all seriousness, this was a really cool case to utilize these digital technologies to the fullest.
Yeah.
And get a good result. And we just got her sleep test in today. And like I said, she was a mild case, but we got success. She's treated well. She's her apnea is controlled, even in a supine position. Heart rate improved, oxygen improved, severe snoring down. This is what we wanted. So I told you that's all I have for that stuff. I told you I have 2 dinosaurs. We have Flossie and, of course, Remy. Get it? REM. Remy the Snornomoris. So our patients are greeted by 2 dinosaurs every day. I dare say I am the only dentist in Delaware, the continental US, possibly the world, with 2 dental themed dinosaurs outside of their office. So I think it's a bold statement, but a statement I'm willing to make. So I wanted to thank you guys for listening to all of this. Awaken to Sleep for hosting me. If you're interested in kind of starting up your journey into dental sleep medicine, revamping, touching up on some skills, they've got a variety of seminars out there throughout the year that are available. Or if you're looking to step up your practice, get some coaching in, and seeing how you can have some of these better workflows that will work with your office and what you guys are hoping to accomplish, definitely reach out to them, see what they have to offer to help you, again, help patients better, because that's what we want to do, make you a better clinician by getting those systems in place and going there. So QR codes are up there if you want to scan and do that. And I'm happy to take any questions you may have.
Andy, thank you. Thank you for tonight. So you were on a roll, man. I was not going to stop you in the middle of the digital workflow piece. But I've got several questions here for you. Some have come through the chat, some through the Q&A, and some privately to me. So I'm just going to kind of pull them together. I'll start first with what Ken asked in the chat. Can you please review the capture of the protrusive bites with the scanner? Just your verbal quick steps. Yeah, perfect. So I'll get, my go-to is airway metrics, but I've also used the George gauge on occasion. I'll put a little bit of bite registration material in the most distal part and have them bite into place and hold that there. And again, if you're not familiar with the airway metrics jigs, check them out. They're my go-to, but it has, so I create this tripodization to stabilize the bite, anterior, posterior. And then I'm able to just scan that protrusive position. And like I mentioned, and I didn't get as much of the futar in the video when we showed it, I try to put a lot back there and give it some topography, because when you have these teeth separated and the airway space, scanners don't like capturing nothing. So they just kind of stop and get confused. So what I'll typically do is I'll start at the lower canine and scan distally until I hit the futar, go up the futar, because it's giving me that
rigid position that the scanner says, hey, this is something I want to make. And then I'll go up to the upper arch and go anteriorly. And that will get us all the information. And then the software can say, oh, it's the teeth. I know teeth. And it will join up in the position there to get that vertical and anterior component.
Awesome. Cool. Okay. What's the material used for the MOG?
We use Sprint Ray's flexible sprint resin that they have. There are a lot, I mean, every time I open up the website and look at all the resins out there for stuff, it's a ton of stuff out there. But I like that material for both my bite splints and the MOGs. I found that some of the harder acrylics, patients feel like they're death gripping their teeth and they really don't tolerate them well. So this material I find gives you the stability you need for the appliance, but also allows them to feel comfortable in it too.
Got it. Tailing question to that, and then we'll shift gears. Would Keystone Soft work? Also, would that resin work for a trial appliance?
Keystone Soft, I would imagine, would also work for the MOGs. Trial appliance, you may want something a little firmer if you're going to do that. Just because if you're working on holding the appliance forward, you're going to want possibly a little more stability. Again, I haven't made those for my patients. I just kind of say, I wear it every night and you're going to do great with it too. So cool. I'm just that positive atmosphere for them.
Awesome. What scanner is best for the ROI just for sleep? If you only had your sleep practice, not your GP side, what scanner would you go with?
That's such an unfair question, but
if you had to cut off your right arm, what would you use your left arm for?
But that's my dental arm, except for root canals. I do those left-handed for some reason. But when it comes to the scan, I really do like the Medit i700. That's what I've been using for a year now. I was iTero for about 9 years there. We're not a heavy Invisalign office, so the benefits of the iTero didn't translate over to it. Was still a great scanner. I know if Bree, my assistant, is on tonight, she would be saying, we love the iTero. But the Medit gives me some more open architecture to work with, other softwares, other things that was important to me for sleep. So using that D3 splint module, working with some of the labs out there that really do have a preference for Medit themselves, it made the most sense for me. And again, if we're talking about ROI, economically made the most sense too.
Got it. Cool. Okay, so I was, this one is actually from me. Sorry.
Sure.
Sorry, not sorry. I'm impressed that your digital clinical workflow also includes a digital task management or project management software that communicates between you and your team. Can you tell us what the name of that is again? And how, just an overview of how you use it.
Sure. We use something called Slack, and it's got a add-on with it, which this is why I need any of my Briannas right now, because they know the full names there, but of that additional software. But if you look into Slack, it will tell you. And again, that it really does give that cool step-by-step where everybody's in the loop with what to do next. And I don't know how clear some of that came in, but that was our workflow from a patient from, hi, I'd like a sleep appliance, to, okay, you're on year recalls. So it really does give everything from writing the letters to the physicians and dentists. It really is helpful for that team communication.
Awesome. Okay, we got some team members on here because I recognize some names. What's up, Abby? If you are the Bree in a practice that doesn't have the tech, or that doesn't utilize the tech the same way you've shared tonight, what tips would you give team members on talking to the docs about doing this from a sleep standpoint? What would speak their language?
Ooh, that's a great question, actually. I mean, in my office, I'm not even going to pretend I'm the boss when a Brianna tells me to do something in the office. I'm like, yeah, that's probably the right thing to do. But in all seriousness, when you're talking to the doc about that, I think the best way is it's improving outcomes, and we know dentists are type A people who are stubborn and stuck in our ways. But if we can talk to them about how you can improve timing, you can get things back sooner, you can have more accuracy, where we're going to have less issues with the lab. When a patient loses something, we're going to be able to respond in a more timely fashion. And then when you start talking about on the number side with 3D printing, well, that night guard that you have the lab make is $109. If you got 7.5 minutes, or you want to teach me how to do something in 7.5 minutes and to print it, we could be saving money and really be able to help that bottom dollar of the practice.
Mhm.
So I think you got to find out what speaks best to your doctor, but there are a lot of avenues to take to talk to them about adapting technology in there.
Cool. Another one, totally shifting gears, just so we can zigzag.
Sure.
How long does it take to make a morning aligner, and what was the material again that you use in printing?
We use the Sprint Ray Night Guard Flex is what we use for both our bite splints and morning aligners. Timing for a morning aligner itself, actually, I don't know for just one morning aligner, because we typically print in batches, so it's 10 things at the same time, which still doesn't take too long. But I've had a patient who, she was in town for the day. Actually, no, it was the oops, this was before Slack, we forgot to print her and she's coming in today and then leaving town. So we were able to, within 30 minutes, print a night guard, process it, cure it, and get it in their mouth. So it can be a really quick turnover, depending on the settings of your printer there.
Got it.
I wouldn't recommend doing it that way. Plan ahead.
For sure. Okay, so I just got the message from my team, the little like telepathy thing. We are at 6:15. I've got more questions, but let me do this. Team, if you can put the CE link in the chat. For those of you that still want the questions answered, you can hang out. For those of you that are good to go, you're welcome to hit the CE link there. Also, we have a link for the course and a consultation with a coach. If you guys have any questions, we're happy to answer them. If you want to hang out on a course and learn how to level up your sleep practice, we're delighted to hang out with you for a whole weekend. If you hang out with us September 23rd and 24th, as it said on the slide, you get a $200 discount. I was supposed to say that earlier. Thank you for that. So yeah, it's in the chat, guys. I'm going to ask these last couple of questions, but for those of you that need to bounce, we understand. Okay, if you had, Andy, this is for you. If you had a completely analog workflow, you're starting from scratch, you have no digital equipment, no digital workflow, what is the first piece of equipment you're going to buy in order to start moving digitally?
Scanner. Definitely hands down a scanner, especially if you're a general office starting in sleep. You're going to find so much use for it. It really, again, I mentioned earlier, you become a better dentist, then you can just kind of brush that comment aside. When you see your crown prep filling an entire computer screen, you start to notice, oh, that may be an undercut. Oops. Okay, let's refine that slightly. Let's make these modifications. So it really does translate over to so many important aspects of the clinical dentistry you're providing the patient. So get the scanner before the printer, hands down.
Got it. And kind of a tailing question to that. Again, if you were sleep only, I know that's the like, ugh. If you were sleep only, would you get a 3D printer? And if yes, outside of morning aligners, what can you print?
100%. If you're a sleep only practice, you can get your return on investment from a 3D printer. I don't really like thermacryl morning aligners because of the fact that they're heat activated. It's the wrong word, but when you tell your patients when you clean it, don't run it under hot water, and they clean it under hot water, you now are no longer capturing their bite. So, and if you don't have any digital reference of that bite, you're out of luck. So the 3D printer, if you're buying morning aligners from the labs, the bill is going to be anywhere from $30 to $60 per aligner. You can easily make that back within a matter of weeks if you're doing all sleep all the time for that. So definitely get that. Again, in our practice, we'll print out models to make Essex retainers if we have patients who are concerned with shifting of teeth. We will print bite splints for patients who have some TMD going along with their sleep apnea, which we know has a lot of correlation in itself, and that's a whole other lecture, so we won't get into that too much.
Sure.
But and again, using models, when we have these patients who have been wearing this Herbst for 4.5 years, and Medicare is not going to pay for a new one until year 5, but it's fallen off of their teeth because it's worn, we can reline it on that model and be able to get a tight fit to get them across that finish line. So there are a lot of uses for it. Again, I'm sure I'm still at the tip of the iceberg of what we can do with it there. So there's a lot more on the horizon. Invest in it now, learn it now, and you'll be able to find something to do with it every hour in your practice.
Awesome. All right. We are 20 minutes past the hour. It's a little bit later your time. So
Yeah.
It's dark outside.
Yes, very.
Last parting words.
Sure. Don't be afraid of this stuff. It really is. It is a great thing to have for your practice. General sleep combo practice. Don't be afraid of it and have fun. Play with these things too, because that's the way you'll learn. That's the way you'll get comfortable. So go for it is really what I say when it comes to digital technology. It's like, it will be worth it.
Yeah. Awesome. Dr. Andy Swiatowicz, appreciate you, man. Thank you for tonight.
Thanks for having me tonight. It's been great talking with you guys. Sorry, I've only been able to see you, but I'm assuming everybody else has been lovely and attentive, and I appreciate you spending some time with us tonight.
Yep. Thank you all. We will see you next time. If you have questions or you want to hang out for the weekend, you guys know the links. Otherwise, have a wonderful night. We'll see you next time.
Thanks, everyone.
See you, Doc.